expert one-to-one training. Individual training and supervision by a practitioner who is expert in these skills is highly recommended if underpinned by adequate theoretical study. It encourages problem-based learning and can be learner-led according to individual needs or speciality. Also, such real-world contexts and consequences not only allow learning to become more profound and durable, but increase the transferability of skills and knowledge from the classroom to work. Common pitfalls. It is reliant on the expertise of one individual, which is therefore limited to their experience and specialist background, and the approach may be ad hoc because expert practitioners will have many priorities to balance. Unum, costly to deliver, limited availability, assessing learning, effective and necessary assessment. The need and effectiveness of clinical assessment is debatable, especially when considering the inherent flaws of assessment processes. Limitations are created by the application of specific criteria to multiple individuals in order to ensure fair, reliable, and accurate assessment. Also, rigid tools may be detrimental to the professional, which Bennett argues results in the definition of practice being reduced to the capabilities of measurement tools. Accurate appraisal from assessment is, however, identified as useful by Burns. Nicklin and Kenworthy outline the benefits of assessment and predict future behaviour, and measure achievement, assess competence, and monitor students' progress, and motivate students. Exactly what assessments measure is important, yet problematic in clinical practice, and this is compounded further because determining competence is difficult, while points out that in general, notions of competence are often confused and misconstrued. The NMC offers some clarity, a bringing together of general attributes, knowledge, skills and attitudes. Skill without knowledge, understanding and the appropriate attitude does not equate with competent practice. Assessments therefore become helpful in determining competence, because they provide clearly stated criteria that enable the learner to demonstrate adequate ability, knowledge, or authority. Professional bodies expand upon such simplistic definitions to clarify what is meant by competence for practice. You must have the knowledge and skills for safe and effective practice when working without direct supervision. It is closely related to scope of professional practice, and encourages practitioners to be aware of their limitations. You must recognise and work within the limits of your competence. The Health Professions Council echoes this. You must act within the limits of your knowledge, skills and experience, and if necessary refer the matter to another professional. Theoretical assessment. Theoretical assessment can be achieved effectively in a number of ways. E-learning based assessments provide different questions each time and so ensure reliability, validity and fairness. Written assessments have the advantage of learners being able to expand on answers. They can be completed in any location, and documentation can later be produced to demonstrate core knowledge as required. The structured learning program offers an example of a written document that is intended to be reviewed with an assessor. In this way, core knowledge is assessed and so assured, but questions can still be raised that may hold particular significance for patient group, previous learner experience, or local and national issues. 2. Venipuncture and cannulation. Self-assessment and reflective practice. Marteau et al. And Crunden highlight difficulties of self-assessment in clinical practice. Learners may not always be able to accurately self-appraise competence, because a poor outcome may be the result of a normal patient variation rather than technique. In the case of venipuncture and cannulation, for example, a learner may consider the procedure a failure if they do not access the vein. In contrast, an experienced supervisor may know the cause to be unavoidable and therefore assess the learner's overall approach as successful. Reasons to adopt. Self-assessment and reflection is recommended by regulatory bodies such as the Nursing Midwifery Council, General Medical Council and Health Professionals Council. The GMC states, graduates must be able to reflect on their practice, be self-critical and carry out an audit of their own work. Unmodified self-assessment tools optimize adult learning approaches while remaining open to drawing on experienced others, a method endorsed by Danifer et al. Runciman et al. Also highlight that irrespective of the subjective nature of intuitive judgment, the expert opinion has much to offer. Summative final examination. National ratification of an assessment framework of these skills is not currently available in the United Kingdom. Indeed, formal final assessments similar to models such as ALS, which certify competence by successful completion, would not be realistic for such highly used skills. Instead, final assessments tools that are locally endorsed could offer a more robust and accessible way forward. All assessments should be designed to demonstrate knowledge, skill and competency achievement and be sufficiently clear in order to avoid the need for retraining when changing roles. Comprehensive assessment guidelines are equally important in order to achieve a valid, reliable and fair assessment. Reasons to adopt acknowledges that learning has been achieved to specific standards. This gives clarity and a goal for the learner while assuring the organisation that a set level of competence has been achieved. It also provides clear evidence to professional bodies in the event of adverse clinical incidents. The objective structured clinical examination is an effective assessment tool commonly used by medical schools in their clinical competence exams and is usually performed in a simulated environment or a skills laboratory. It is a clear and concise tool. The OCSE in its original simulated environment is argued as inadequate as a sole method of assessment for nursing students because it does not accurately replicate a ward environment. However, adaptations to the OSCE to make it applicable in the clinical environment yet still objective have been made by the VAN and were reported as successful by Collins et al. Professionals Learning, Adult Learner. Lorge, writing about effective methods in adult education, suggested that to reach the adult learner you have to teach what adults want. He stated that adults have wants in the following 4 areas. 1. To gain something. 2. To be something. 3. To do something. 4. To save something. 2. Venipuncture and cannulation. Multi-professional learning. In the late 1990s, in many hospitals, junior doctors had responsibility for cannulation, although Doherty reported that specialist nurses in the fields of cancer, cardiac and intensive care also fulfilled this role. Currently, it is carried out by a range of suitably prepared healthcare professionals, including, but not exclusively, nurses, paramedics, radiographers and healthcare support workers. The government and professionals endorse training and competence over a role-specific approach. Intravenous cannula insertion will be carried out by trained and competent staff using strictly aseptic techniques. It is suggested that cannulations are less traumatic when carried out by someone who has regular practice. Lavery also highlighted that frequent practice in enhanced clinical skills is essential. The decision as to who should practice venipuncture and/or cannulation should therefore be based on whoever is best placed to learn, maintain and update their skills. It should not be determined by professional status, prior experience or enthusiasm. Each professional group will bring to these skills relevant experience according to their background and primary task. The primary task of a doctor, for instance, could be identified as diagnosing, compared to a nurse's primary task of caring. This understanding is useful when trying to understand puzzling responses or feelings of anxiety that can block competency achievement for these skills. Nurses, for example, must initially shift their role focus from caring to curative, which may feel strange because it is at odds with their primary task. Likewise, a radiographer may feel challenged by doing more invasive procedures when compared to their regular diagnostic primary task. It is important that professionals are able to take time to integrate these skills into their practice in a way that works best with their own primary task. Similarly, it is important for learners to appreciate the value of their own approach as well as those of other professionals, as the patient's experience may be equally positive. For example, a surgeon whose technical ability is critically important to his/her role will have become an expert in the intricate psychomotor aspects involved in cannula placement. Initially, this could be considered by the patient as favourable when compared to a carer with less developed psychomotor skills. However, in light of Bohr's findings that anxiety can produce a similar physiological response as acute pain, the intensively developed communication skills of a carer may be of equal value to the patient. In this way, while the approach may vary, the level of pain and confidence experienced by the patient may be similar. Post- and pre-registration nurses. Pre-registration nurse training does not normally cover venipuncture and cannulation within the curriculum, necessitating the need for post-registration training. A standardised pre-registration programme would help improve the practice of these skills and has been explored by the NHS in Scotland. Training may be incorporated into pre-registration training in the future, a concept which has previously been discussed for intravenous therapy. Currently, students should confirm the policy with their educational institution and placement organisation. They particularly need to ensure that it is appropriate for their stage of development and placement specialty, and that they have the expected training and assessment required for these skills. Post-registration nurses must follow professional guidelines and local policy. If acquiring or refreshing their skills, you must take part in appropriate learning and practice activities that maintain and develop your competence and performance. Allied healthcare professionals. At times, it will be appropriate for an AHP to be trained prior to registration because these skills form an integral part of their work. And assessment resources. Identify local learning opportunities, realistically assess the complexities of learning within her own workplace, consider her own and other professionals' needs when learning, plan a successful route to achieve competency. Introduction. This chapter explores different approaches to education, training and assessment for venipuncture and cannulation. As courses differ locally, strengths and weaknesses of educational methods are highlighted so that learners can avoid common pitfalls and identify potential resources. Competence is a theme throughout, but has been specifically related to assessment approaches. The environment of work and learning is discussed, drawing on behavioural sciences to offer illumination on the complexities involved in learning at work. Different professional groups are later introduced, so the learner can consider specific educational requirements for themselves and those around them. Learners will benefit from taking time to consider if it is realistic and appropriate to acquire these skills in terms of gaining competency and maintaining expertise once competent. Training, education and development is only effective if what is being taught is needed and wanted, and the reason for poor current uptake understood. Major suggests these fall into two simple rules. Rule 1. Training is appropriate only when two conditions are present. There is something that one or more people do not know how to do, but need to be able to do it. Rule 2. If they already know how, more training won't help. Knowledgeable and practical learning, theoretical learning. The clinical area is rich with stimulating learning experiences, but this can also be challenging for learners because it is also distracting. Learners therefore benefit from protected time in an environment conducive to acquiring theoretical knowledge, including anatomy, physiology, specialised terminology and equipment design. An environment which has been designed for learning encourages active questioning, because it should feel safer and less exposing for learners. Equally, patients need not experience discussions that may be anxiety-provoking and irrelevant to their own situation. This falls in line with the essence of care benchmark for communication. Communication takes place at a time and in a communication environment that is acceptable to all parties. Any division of theory and skill must be done carefully because it creates an artificial split that does not reflect the reality of healthcare roles, which require thinking and doing together. Benner et al. Informs us that expert nurses make decisions about care by thinking in action, which is particularly relevant for these practical skills. Theory remains essential to provide a solid foundation to enable safe practice, but should not be the sole source of knowledge and understanding. Indeed, it is too limiting for these skills because normal patient variation creates unpredictable outcomes that need to be learnt in practice. Mastering these skills therefore requires the learner to source learning tools and methods that are designed to include key theoretical elements, but also have a fundamental objective of facilitating integration of practical skill with theory. Table 2.1 Key Theoretical Knowledge Required. Anatomy. Anatomy and physiology of the normal arm, including skin, veins, arteries and nerves, and the feel and appearance of healthy veins, including the presence of valves and junctions.